Thank you for being here. Thank you again, everyone, for your attendance, for just making this meeting happen every 2 years. Thanks again to the sponsors. I did not have many sleeps recently, so apologize if I'm not completely fluid in my presentation, but so yeah. In the lab that I joined 10 years ago now, the I3 lab at Sorbonne University and led by David Klatzmann, we are interested in autoimmune diseases and inflammatory disease. And the interest of the lab was mainly focused on the role of regulatory T cells in those diseases. Indeed, you all probably know that for most of the autoimmune diseases, there is an imbalance between regulatory T cells and effector T cells. And when I said here effector T cells, I'm mainly talking about CD4 helper effector T cells. So the imbalance means what? It means that, sorry, I did not, yes. In a normal immune system, I don't know what normal means, but at least in a healthy immune system, there is a balance, which is not necessarily in numbers as depicted here, but regulatory T cells are in a shape, in a functional state that allows them to control effector cells in their possible pathogenic response. In autoimmune context, this balance goes toward effector cells, and what makes this balance being lost? It's either a number of Tregs, but maybe also the quality, the composition of the regulatory T cell compartment. So David and others pioneered the study of the restoration of this imbalance by providing low-dose IL-2 to patients. Why? Because Tregs are really dependent on interleukin-2, and this cytokine is really important for their functioning. And when you provide it at low dose, this small dose just trigger and activate Tregs. So we can restore, patients with autoimmune diseases that were given with low-dose IL-2 have improved clinical status, which means that, yes, Tregs are really playing a role in those diseases. As you also probably know, regulatory T cells, they derive in part from a thymic precursor, so they are differentiated there. And during this differentiation, what we believe is that they are selected based on their T-Cell receptor and for their capacity to recognize self-antigens. But yet, the antigen specificity in general of regulatory T cells, it's not really resolved. And this is true in health, but also in disease. So David launched more than 10 years ago now, a big trial that was called Transiminum, that aimed at studying the role of regulatory T cells and the immune system in general in autoimmune diseases. So in this trial, which was an observational trial, different 500 patients with 1 out of 19 autoimmune disease or inflammatory disease were recruited. The idea was to analyze those the immune compartment of all these patients by a deep clinical and immune monitoring, including also microbiome monitoring. For that, we collected blood samples, and different assays were performed on these blood samples, including immunophenotyping, autoantibodies collection, proteomics, transcriptome, and TCR Repertoire. And those two omics approaches were applied on sorted regulatory T cells and effector T cells. Again, that was with the aim to better understand the role and the modification of those cells in this disease. We also, as I mentioned, got the gut microbiome from the stools from those different patients. So today I'm not going to enter into all these studies and all the different omics approaches that we are doing in the lab, but I'm focusing on what can we learn from the TCR repertoires in this framework and in other studies that we performed. So, one classical way to analyze the repertoire is to look at diversity, to look at the composition, to look at the clones distribution. And we thought that maybe what would be interesting, especially because we have this large cohort of patients with different diseases, was to try to identify what makes those patients with these autoimmune diseases different in terms of repertoire, and try to search and to look for TCRs that could be associated with each disease. So we started this study by focusing on 3 groups of individuals: patient with type 1 diabetes, a patient with rheumatoid arthritis, because there were 2 diseases with a T-cell component in their onset and their pathological development. And we compared those patients with healthy volunteers, for which actually we got exactly the same data as the one I introduced before. So on all these individuals, we collected, as I said, the blood, and we sorted effector cells and regulatory T cells, and then we applied, we wanted to apply TCR repertoire. So one thing that I want to mention, because this was a lot of work that was done in the lab and also within the AIR community, is that here we had many samples to analyze. Extended to the whole cohort, it was more than 1,000 samples, because for each patient we have 2 samples for the repertoire. So we really needed to have methods that could be reliable and that could be robust across all our studies, across time also, because we were not able to do everything at the same time, especially regarding the patient recruitment. So we launched a benchmarking of different methods. Different approaches, different protocols were compared, and we made our choice based on what we needed to address the question we had, which was analyzing the repertoire of 2 different subsets, one which is quite large, for which we know the diversity is high, and one that is much lower, and for which the diversity was not really clear. And I'm stressing really on that, because I think this is something we should continue doing, because tools, approaches, protocols are evolving, and we should not just think that we can use them once and use another one afterwards. So, what did we do to try to identify TCRs that could be associated with disease? So we used different approaches, and finally we ended up using discriminant analysis based on partial least square that allows us to select in an unbiased manner features that could separate a group versus another one. So the way we did it was that we systematically compared the repertoire of patients in regards with healthy volunteers, which means either type 1 diabetes patient in that case versus healthy volunteers, or rheumatoid arthritis patient versus healthy volunteers. So with this PLSDA approach, we could identify some features, which in that case were CDR3s, and we focused on CDR3s for this first approach. Because our data set was not that large, I mean, we had 50 to 60 patients. It's not a big cohort. Instead of doing classical cross-validation for the evaluation of the prediction of this to train the models and to test the model, we decided to do a leave one out, which means that we apply this feature selection on all the individuals to be compared, -1, and we repeated this as many times as we had the samples. So we, at the end, obtained a list of CDR3 that was separating and discriminating patient versus healthy volunteers. As a control, we use a standard, we try to, not a standard, sorry, a random signature. So that means we selected a number of CDR3s similar to the one that was identified by the feature selection, but we took random CDR3s across our dataset. And that was for us kind of control of whether our signature was close to the random or not. So those are the results that we obtained for regulatory T cells and effector cells, because we applied this method to the different type of samples. And here I'm showing the percentage of classification, of good classification of each patient according to the different disease for the alpha chain, the beta chain, the signature here that's the feature selection based signature, and the random signature. So as you can see, we put as a threshold 80% of classification to ensure that what we obtained was robust enough. And as you can see, the signature obtained by the feature selection was always higher than 80%, and importantly, higher than the random signature that we tested. Even if the random was apparently lower than the feature selection signature, something that was a bit striking is that the random was able to separate our patient anyway. So meaning that somehow we may have noise, we may have group effect, and we did not, well, that was a bit scaring about how confident could we be on this type of approach. So to have a look on in a different way on how those signatures were separating our patient, we then just took all the sequences obtained in the signatures, and we just applied the hierarchical clustering, taking all the CDR3s that were obtained for the alpha, the beta chain from type 1 diabetes patient and rheumatoid arthritis patient and healthy volunteers. And by hierarchical clustering on here effector cells and here on regulatory T cells, you can see that we can nicely separate healthy volunteers from the patient, which was expected because that's the way we applied our feature selection, but also the patients that were never compared between them, between each other, rheumatoid arthritis versus type 1 diabetes. So that was reassuring, but still we wanted to be sure that, again, those signatures were not something that could just happen because you are using approaches that separate as much as possible your samples. So the next control that we did was a sample permutation test, which means that we mixed, we changed the label of our samples. So our sample was relabeled healthy volunteers and vice versa. And we checked whether by doing this, we could identify what was the percentage of CDR3 within our signatures that was present, that was able to separate those two groups. So those are the results for rheumatoid arthritis, here for type 1 diabetes, TF, Tregs in both cases. And what you can see is that the slope of the signatures of the percentage of CDR3 separating the RA patient was significantly different than that of the permutation groups, suggesting that what we found in our RA signature was separating correctly the patient. But interestingly, or well, initially it was a bit disappointing, but maybe it's not. Maybe there's a biological meaning relevance behind this. When we did the same with the type 1 diabetes signatures, that was able to discriminate and that was able to classify correctly our patients. You can see an overlap between the percentage of the CDR3 in our type 1 diabetes versus the percentage of CDR3 from the original signature in completely random labeled samples. So suggesting that the type 1 diabetes signature was either a group effect or maybe just separating samples by chance. So we continued on the rheumatoid arthritis signature, and we tried to see whether we could identify it in different cohorts. At that time, the rheumatoid arthritis cohorts were not really available, so and we could not find others even now. So we identified samples, TCR Repertoire from juvenile idiopathic arthritis, which is not rheumatoid arthritis, but we believe that it's a disease maybe that at least affects the same type of tissues. And what we found was that the signatures that we obtained here in rheumatoid arthritis patient could be detected both in effector cells from different compartments from which those repertoire were performed by the team, and as well as regulatory T cells. So that was kind of reassuring that at least those sequences could be identified in other groups. So I'm not going to go into more details because Paul Stis, who is present here, is going to present his poster about the topic, and he went even further because he is now analyzing the CD8 compartment from the same samples and providing a new insight into this approach of TCR signatures in autoimmune diseases. We then in another project that is led also by David, that aimed at evaluating the effect of low-dose IL-2 in autoimmune disease, and especially in SLE in lupus patients, we wanted to determine whether low-dose IL-2, that I remind you is triggering regulatory T cells and inducing the proliferation of regulatory T cells, whether we could predict the response to this treatment and whether the repertoire of Tregs is modified upon this treatment. So the clinical trial, the low-dose IL-2 treatment, so lupus patients that were recruited in different centers across the world were treated with low dose during 5 days, and then they had different shots of low dose IL-2. And before each treatment, we could collect blood samples, and applied the repertoire analysis. So here I'm just showing you the result of the clinical trials, showing that regulatory T cells are increased and quite early after the first day of treatment, showing that low-dose IL-2 it's targeting those cells and not effector cells. So we did previously the same approach as previously, and I'm showing you. I'm going to show you some results that we obtained, first on analyzing the baseline samples and the samples after the 5 days of low-dose IL-2 treatment. So here we first analyze the diversity, because we have no idea of what could happen in terms of diversity. So we analyze the diversity, and here I'm showing you the Shannon entropy as a diversity index for the alpha chain, the beta chain of effector cells and regulatory T cells at day 5 after the treatment. I put here also the healthy volunteers as controls, and those healthy volunteers were not treated, of course. So Patients with lupus were either treated by low-dose IL-2 or with placebo, and you can see that there is no differences in terms of repertoire diversity between healthy volunteers and the lupus patient treated or not in the T effector compartment. However, on the regulatory T cell compartment, we can see that a patient that lupus patients that received the placebo, so that were not treated with low-dose IL-2, had a lower diversity as compared to healthy volunteers, while a lupus patient that received low-dose IL-2 had a restored diversity that became comparable to that of healthy volunteers. So suggesting that the impact of low-dose IL-2 on the proliferation of regulatory T cells induced also a modification of the repertoire. We then looked at the correlation between the diversity that was measured again with the Shannon index and the disease activity. Again, there is no association at all, no correlation between the diversity and the disease activity when we looked at the effector compartment. However, when we looked at the regulatory T cell compartment, there is an inverse correlation of increasing diversity with decreasing disease activity. So the more clinical improvement, the more diverse is the regulatory repertoire. You will have more details on this study also by looking at Martin's poster, where he applied the signature approach to see whether we could identify either treatment or immune response to the treatment signatures. And we have now some promising and interesting results. So to conclude on this, I don't know how I'm fine? No? I should stop? Okay. So I'm not going to go on to the second part. So we have this machine learning approach that allows us to identify signatures in autoimmune disease, which was not that trivial to envision, but we found something. We still need to confirm this, and confirming this means having additional cohorts testing on different samples. We also need to know what's the biological relevance of those signatures. Is it just a biomarker? I mean, the repertoire is changing. Some T cells are going somewhere and others are still circulating in the blood, and this is what we are seeing. Does it reflect a collection of maybe antigen-specific clones that could be circulating from the inflamed tissue? So those are questions that we are now trying to address by using different approaches. I'm going to skip all of this. And I want to thank all the lab members. First, David Klatzmann, that put all together these different studies, and that really help us having those challenging questions. All the PhD and postdoc students, most of them are here, and that have been doing all this great work, and all the collaborators.
Hello, there we go. Very scary. I'm scaring myself. So I think we have a couple questions in the Slido. There we go. Okay, so the first one, you now have what looks like a pretty good classifier to separate RA from healthy volunteers, but how will you use it? How may you translate this into something that's clinically useful?
So to answer that question, it's what we need to know. It's what these classifiers means, in fact, and definitely how could we use it? This is one of the most challenging questions. If there is some antigen specificity behind, maybe we could use this to, I don't know, to promote immune responses or something. But yeah, at the moment, it's a classifier.
Yeah, I mean, it's early days, right? So you have to start with that and then build, right? So if you combine, the next question, if you combine the CDR3 signatures from the T effector cells and the regulatory T cells, can you get better discrimination between patients and controls than with either alone?
That's a great question, and Paul has been addressing that question by doing all the possible comparison, TFs alone, TF, TRA, TRB, TRA alone, TRB alone. So in fact, by combining both, we are not getting better results, as far as I remember, Paul.
Don't remember, okay.
But no, in fact, there was no synergy in the way we could classify.
That's interesting in and of itself. Yeah. So how might sex bias impact your classifications?
That's also a good question. So in the type 1 diabetes cohort, I don't have the 6 ratio in mind, but we may be around 50-50, while in rheumatoid arthritis, it's mainly a woman. So that, again, depends on the disease. But this is something that Hélène, as you saw, she was working, she worked on those samples from organ donors. So now she's going to analyze those data with this sex ratio, this sex association or not.
Yeah, or maybe take a subset of the healthy volunteers who are women and do an analysis that way. Yeah. Regarding the lack of relevance of a classifier in T1D patients, does it appear that their signature is somehow similar to that of healthy volunteers?
The signatures are different from the healthy volunteers because the way the feature selection works, it's identifying CDR3s that are present in one and not in the other. So they are different. Why they are not separate, why they are not working, what we believe is that maybe, so type 1 diabetes, it's especially the patient that we analyzed. So there are patients with type 1 diabetes that was diagnosed many years ago. So maybe the immune response related to the disease onset is not really there anymore. And what we just identified was a group separation. So we had a group of individual A, type 1 diabetes, a group of healthy volunteers. And because we applied the methods that we said, okay, give me everything that separates the two groups, the methods could identify a separation. But then when you mix it, again, probably almost the same.
Diluting out the signal, yeah. So that's really interesting. I mean, maybe in the T1D group, if you stratified it by length of disease or activity.
Yes, so what we are going to do now is to work on pediatric samples on kids that are at high risk of developing type 1 diabetes and that are at the onset, early stage of the disease development.
Yeah, and I think we have time for one more question. So let me try, how large is the overlap between the T effector and T regulatory compartments? Are there signatures that are pathogenic in one and not the other?
The overlap, at least when we analyze it using similarity indexes like Morrissey-Tahorn or Jacquard, the overlap was almost zero.
Makes sense.
But we are in the blood.
Yeah. Okay, great. Thank you, Encarnita.